Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication. Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
My name is Dr. Saihari Sadanandan. I'm the Director of Tampa Cardiovascular Interventions and Research. I'm an interventional cardiologist at 3 different hospitals in Tampa: St. Joseph's Main Hospital, St. Joseph's Hospital North, and Advent Health Calwood Hospital. I'm here to present my case using intravenous Aggrastat in a patient with intraprocedural thrombus formation in his coronary arteries. The purpose of this video is to demonstrate a typical use of Aggrastat for fellows and those who may not be familiar with contemporary use of 2B3 inhibitors. Here are my disclosures. I have received financial support from Medicure, the manufacturers of tirofiban, for the creation of this video. So let's dive into the clinical presentation of this patient. Here is a 74-year-old male with hypertension. He has known history of coronary artery disease and had a PCI more than 8 years ago in an outside institution. He was originally evaluated in the emergency room for worsening angina. He was admitted. His troponins were very mildly elevated at 0.1. His echo LVEF was normal. Given his chest pain and very mildly elevated troponin, he did undergo a cardiac catheterization that demonstrated a chronic total occlusion of the right coronary artery with occlusive chronic instant restenosis of the right coronary artery. There were collaterals from the LAD filling the distal RCA. Since we felt that this was a chronic stable situation and he became pain-free upon arrival to the hospital, we decided to treat him medically first with intensification of his blood pressure and anti-angiogenic medications. He was on amlodipine, Imdur, and we added Ranexa, and he was discharged home. He was then seen in office, and he continued to have lifestyle-limiting angina. So given the fact that he had only chronic total occlusion, we want to make sure that he has inducible ischemia in the distribution. Hence, the patient underwent a stress test that did demonstrate inferior wall ischemia. Given his ongoing symptoms on maximum medical therapy, a documented ischemia, and a chronic total occlusion of his right coronary artery, he was referred for a complex CTO PCI of the RCA. He was brought to the hospital as an outpatient. The patient was already on aspirin and Plavix. We decided to use heparin for anticoagulation during the procedure, and the ACT was maintained a high level between 250 and 300 second range during the procedure. Before we go into the cardiac cath findings and revascularization strategies, As a refresher, Aggrastat or tirofiban hydrochloride is a reversible antagonist of fibrinogen that binds to the glycoprotein 2B3A receptor, where it blocks the final common pathway of platelet aggregation. It has a 2-hour half-life, and platelets return to normal function between 4 to 8 hours after you stop infusing. Aggrastat provides a very potent and rapid platelet aggregation inhibition and has a very consistent response across patient population. Importantly, through its mechanism of action, Aggrastat has the ability to disaggregate an existing thrombus, which neither an anticoagulant like heparin or a P2Y12 inhibitor can do. However, there are limitations to what thrombus it can disaggregate. Typically, it works best on a fresh thrombus. So back to our case, this was our strategy based on his previous angiogram. We knew he had a chronic total occlusion of the right coronary artery with a previous stent in the mid portion. We decided to use a standard hybrid technique and dual catheter injection with catheters both in the right coronary artery and the left coronary artery. Using dual injections, we crossed the chronic total occlusion successfully with a pilot 200-300 centimeter wire and a turnpike support catheter. The distal intraluminal location of a wire was confirmed via injection beyond the level of the occlusion, and then the wire was exchanged for a regular workhorse run-through wire. Since the patient had diffuse instant restenosis, we decided to perform laser atherectomy, which was performed throughout the course of the right coronary artery from the proximal portion to the distal portion inside the stents. Following laser atherectomy, the lesions were evaluated with an intravascular ultrasound for sizing, and then we treated these lesions with balloon angioplasty using a 3.0 millimeter balloon up to 12 atmospheres. Angiogram at this point of time surprisingly demonstrated a distal RCA occlusion. We were unclear whether this was a dissection or a abrupt closure from a dissection or thrombus formation, but we quickly ruled out dissection with a contralateral injection, which confirmed it was indeed an intra-procedural intracoronary thrombus that formed during our procedure. We quickly checked an ACT. The ACT was 288 seconds, which is where we wanted it to be. Given the situation, we quickly decided to do a thrombectomy. So a penumbra coronary device was advanced into the RCA, and thrombectomy, mechanical aspiration thrombectomy was performed. But despite that, there was a persistent thrombus and slow flow in the right coronary artery in the distal portion. At this point of time, we decided that we should proceed with intravenous Aggrastat bolus and infusion to resolve this intra-procedural thrombus. Following initiation of Aggrastat, we then proceeded with balloon angioplasty of the distal RCA with improvement in thrombus burden and establishment of TIMI3 flow in a large RPDA branch. However, the RPL branch still remained occluded with thrombus at this point of time. Since these were areas which had no disease, no significant stenosis before, we decided to proceed with stenting of the RCA now that we had established TIMI3 flow in the RPDA, while we were waiting for Aggrastat to initiate its own thrombolysis and antithrombotic effects. The RCA was then stented with overlapping 3.0 times 30 millimeter, followed by 3.5 times 38 millimeter and 3.5 times 24 millimeter resolute onyx drug-eluting stents from the distal portion all the way to the proximal portion. The stented segments were then post-dilated according to the IVUS measurements with a 3.5 and 4.0 millimeter non-compliant balloons aggressively. While we were stenting and performing balloon angioplasty, post-dilatation of the RCA, we started noticing that the flow in the RPD and RPL began to improve with resolution of thrombus with continuation of Aggrastat. And our final angiogram, following adequate post-dilatation, demonstrated complete resolution of residual thrombus in the RPDA and RPL and prompt TIMI3 flow with no distal cutoff and filling of all distal branches. We then proceeded with closure of the access site. The patient left the lab with no chest pains, no SC segment changes on the EKG. We decided to continue Aggrastat for at least 4 hours after the procedure, and the patient was sent back to his recovery area. So here are some of the takeaways from this case. Aggrastat can be used in patients with intraprocedural thrombus formation during a complex PCI. In this case, intraprocedural thrombus occurred despite pre-treatment with dual antiplatelet therapy and high ACTs in a complex PCI case. Prompt recognition, thrombectomy, and use of IV Aggrastat bolus and infusion can help resolve thrombus and establish successful TIMI3 flow. Aggrastat use in this particular patient facilitated a successful PCI in a patient who had intraprocedural thrombus formation. Thank you for watching, and if you have any questions, please reach out to the Aggrastat team for more information.